Welcome to everybody. My name is Marta Cremonesi. I work at the European Institute of Oncology in Milan, Italy, and I will provide an overview of the patient-specific dosimetry and absorbed dose effect relationships in lutetium molecular radiotherapy. I have no conflicts of interest. As briefly outlined, in this presentation we will consider in particular lutetium dotatate therapy for neuroendocrine tumors and lutetium PSMA therapy for metastatic castration-resistant prostate cancer, taking into account that these are systemic treatments and different diseases are considered. Of course, there are different organs at risk, tumors of different characteristics, and then also different parameters, clinical parameters, to evaluate the benefit of the therapy. The major issue is that in both therapies, lutetium dotatate and lutetium dotatate, the dosimetry studies have shown a very large interpatient variability in both the organs at risk and tumors. And in this slide, you can see a summary of the results published for lutetium dotatate as regards the kidney absorbed doses and the tumors. And the problem of variability is present not only in the older studies based on planar dosimetry, but also in the more accurate studies based on 3D. This slide shows the absorbed dose results for lutetium PSMA coming from different groups, and again the highly variable absorbed dose values for both the normal organs and the tumor. So overall, while inter and intrapatient variability exists and is associated to different patient characteristics, organ functionality, reserve, tumor type, tumor burden, clinical history, and also the possibility to protect or not organs at risk and to dosimetry methodological aspects. But overall, fixed activities and number of cycles lead to a highly variable absorbed doses to both normal organs and tumor. Besides any consideration about rationales and regulation, for both lutetium dotatate and lutetium PSMA, the administration is based on fixed amounts of activity and a fixed number of cycles, and dosimetry is not required, but is applied only depending on the centers and the doctor's demand. As good news, many studies now provide significant absorbed dose effect correlations and evidences in favor of dosimetry, not only in papers that concern a nuclear medicine discipline or medical physics, but also the oncology discipline with journals considering such as Lancet Oncology, JCO, and Nature. The following slides focus on the results on lutetium dotatate therapy, which is a peptide receptor radionuclide therapy addressed to neuroendocrine tumors, having as major organs at risk the kidneys and the bone marrow. As concerns the kidneys, absorbed dose versus renal toxicity correlations were found in yttrium-90 PRT for yttrium-90 dotatate in particular, and about 2 decades ago. The curve obtained correlated the absorbed dose to the kidneys as mean absorbed dose values versus the incidence of end-stage renal disease. The curve was quite similar to that obtained for external beam radiotherapy according to the publication from Emami 1991, but when considering the linear quadratic model, the conversion of absorbed doses into a biological effective dose allowed the two curves to be almost overlapping, and this was a very nice result obtained for yttrium-90 peptide therapy. But yttrium-90 and lutetium do not necessarily have the same impact for the same molecule. The question is, do the same biological effective dose values obtained for yttrium-90, do these apply also to lutetium? So it is possible to extrapolate mean absorbed dose constants for toxicity for from yttrium-90 to lutetium. Is that simple? Well, the fact is that the linear quadratic models applied in the hypothesis of uniform absorbed dose, which is almost acceptable for yttrium-90, but not for lutetium, as shown in this picture derived from authorography in the publication of Mark Koneinenberg. Intrinsic dose volume histograms are different, and the higher non-uniformity of lutetium should mitigate the renal burden, suggesting a higher tolerability for lutetium versus yttrium-90 for a same mean dose provided, and subsequent clinical evidences confirmed this model. Concerning lutetium dotatate therapy and absorbed doses to the kidneys, here are the most important issues. First, there is the large interpatient variability with, for example, a range of 0.3 to 2.0 grays per gigabecquerel with up to a factor of 6-7-fold difference among patients as obtained by the group of 177Lu and shown here in the graph. With a standard approach of 7.4 gigabecquerels and 4 cycles, the patients receive usually 16 to 30 grays to the kidneys, remaining in the safety area. But renal toxicity is extremely rare for the reasons described before, and mostly are related to particular patient conditions. So what we can highlight is that many patients could receive an under-treatment and have received an under-treatment. So no toxicity issues mean that no models can be derived and no constraint for the kidneys, no limit to the kidneys for lutetium dotatate could be indicated at the moment. To summarize the thresholds for the kidneys, as regards yttrium-90 PRT in 3 or more cycles, a limit of absorbed dose of 27 grays can be considered, or a limit of 40 grays by means of biological effective dose. As concerning instead lutetium PRT, the threshold limit has not been found yet, with the usual schemes applied and the activity applied, but for sure the limit should be higher than 23 grays in 4 or more cycles, and of a biological effective dose higher than 40 cycles in patients with no risk factors, possibly due to more non-uniform irradiation. The prediction of bone marrow toxicity in many molecular radiotherapies remains a challenge, and in particular in lutetium PRT, the blood model seems not to be very useful to predict toxicity. In any case, some recent studies are focusing on the image quantification of SPECT CTs, looking for the activity in the vertebra in particular, and so some results very interesting are emerging, such as in this paper from the group of Unideveraja. The authors combined some macro dosimetry with microdosimetry calculations, considering not only the activity that are evaluated from images, but also the cellularity fractions that are characteristic of the bone marrow, considering the red marrow source, the yellow marrow, and the trabecular bone. So in particular, they could find significant correlations between bone marrow dosimetry and platelet variation versus time. As regards efficacy in lutetium PRT, absorbed dose response dosimetry studies have been provided, starting from the paper from Sandstrom and colleagues from Sweden, 2013, showing a protocol with limits setting based on absorbed dose to the kidneys of 23 grays and 2 grays to the bone marrow. And they increase the activity and by the number of cycles in order to reach these limits. So they provided the evidence that more than 4 cycles could have been applied in 50% of the patients, increasing the amount of the activity received. And the clinical results from this study has been published in 2018, showing an improvement by means of progression-free survival and overall survival in patients who reach such limit to the kidneys as compared to the other patients. So highlighting the possibility to improve PSF and overall survival without increasing the toxicity. Another very important paper is this one of 177Lu and colleagues. They applied a different protocol to 96 patients, setting the limits of 28 grays as by means of biological effective dose to the kidneys and 2 grays to the bone marrow. And they observed no renal toxicity. Again, they could apply more than 4 cycles in many patients. And these graphs show the advantage by means of survival probability, considering all the patients and stratifying the patients, considering the different absorbed doses, 23 grays, 23 into 29 grays, and more than 29 grays, and showing the improvement of survival in patients who could receive higher absorbed doses. Another important approach, dosimetry-based, has been provided by Jean-Mathieu Beauregard and colleagues from Canada. They prescribed an absorbed dose to the kidneys of 23 grays as mean value and in 4 cycles. So they fixed the number of cycles and injected the activity depending on each patient in order to reach the absorbed dose to the kidney. And the first clinical results showed a good response rate and no toxicity, but especially 1.5-fold higher activities as mean values could be injected to the patients. Taking this into account, it is nice to compare with the results obtained by the group of Katharina Schroeder and Gleisner, who demonstrated the variation of tumor absorbed doses versus the number of cycles. They observed a decrease over cycles, much more pronounced, especially in patients having grade 2 neuroendocrine tumors as compared to less aggressive tumors. And so overall, it seems that it is important to lower the number of cycles to avoid very low absorbed doses in the last cycles, while the absorbed doses to the kidneys do not vary over cycles. So this approach seems to be a possible future more favorable rationale. 2024 has been a very productive and happy year for lutetium PRT, with many relevant results concerning tumor absorbed doses and dosimetry. In the first group by Magdalena Mileva and the group from Belgium, the authors show that an absorbed dose to the tumor decreases over treatment cycles, confirming previous results, but especially they show that there is a minimal tumor absorbed dose predictive of dosimetry at the first cycle, predictive of the outcome in patients with neuroendocrine tumors in the gastrointestinal tract, with a cutoff of 35 grays. And here you can see, in fact, the progression-free survival curves over time, with very distinguished curves with this cutoff in patients with this cutoff. Another very important result has been provided by the group of Emmanuel Desire and colleagues from France, showing that there is a minute total absorbed dose cutoff value of about 90 grays, allowing to distinguish patients, stratify patients for overall survival and progression-free survival, showing significant different curves in these two categories of patients. They considered the median absorbed dose over 4 cycles from the arithmetic mean absorbed dose of all the tumors considered. And they also provided the tumor control probability versus the total absorbed dose to the lesions. The third study with the most important results comes from the Swedish group of Katarina Schulgen-Gleisner from Lund and colleagues, again showing a relationship between observed dose to the tumors and response to the therapy. In particular, they provided a TCP tumor control probability curve versus observed dose with a 90% of probability for partial tumor response at cumulative observed doses of 135 grays. And they also highlighted a clear relationship between observed dose and volume reduction in both cases in G1 net and especially in G2 neuroendocrine tumors. The last paper by chronological order comes from the Italian group, from Marco Macauro and Carlo Chiesa group. They defined a global tumor absorbed dose parameter by means of a weighted mean absorbed dose for all tumors, and they find out a cutoff of 10.6 grays at the first cycle, derived from the ROC curve. By multivariate analysis, they showed that the mean global tumor absorbed dose is the major predictive factor for efficacy, together with the tumor extension. In these graphs, you can see the progression-free survival curves stratified in red and green lines for the two categories of patients, and very distinguished curves. And then they provided also a curve showing the probability versus the global tumor absorbed doses by means of the progression-free survival at more than 2 years. The following slides focus on lutetium PSMA therapy addressed to metastatic castration-resistant prostate cancer, and the organs at risk in this therapy are essentially the salivary glands, the bone marrow, and the kidneys. As regards lutetium PSMA and the possible side effects, in particular regarding the kidneys, we have to consider that lutetium PRT and lutetium PSMA are completely different radiopharmaceutical addressing different diseases and especially involving patients with a very different clinical history. This paper provided some evidences of effects on the kidneys on long-term nephrotoxicity in patients receiving at least 4 cycles of lutetium PSMA, with a moderate EGFR decline in 45% of patients after 12 months from the initiation of therapy, and severe EGFR decline in 24% of the patients, and even further decline over time in patients with further longer follow-up. Of course, the authors also highlight that the risk factors at baseline are associated with a greater EGFR decrease, which is something that have been expected, at least considering the experience from PRT. Unfortunately, this study do not provide the absorbed doses, as these patients did not receive any dosimetry study. But of course, this information is recognized to be very important for the future comprehension and the therapy application or the possibility of retreatment. From the same group of patients, the clinical details of 3 patients who developed a severe chronic kidney disease and underwent retreatment, receiving 8 to 10 cycles, are reported in this paper. But again, dosimetry is not available, unfortunately. In any case, questions about risk versus overall survival and quality of life, of course, raise. Considering the correlation between absorbed doses and the tumors and response for lutetium PSMA, there is a very nice paper from Melanie Hoberg and colleagues that focus on tumor to kidney dose absorbed dose ratio. And in fact, they found that there are significantly higher absorbed doses achieved in bony lesions and lymph nodes in responder patients as compared to non-responder patients. And they also suggest that it might be possible to estimate the response to therapy from the tumor to kidney uptake ratio from a PET-CT scan. Finally, as regards the absorbed dose versus response correlation, it is to be reminded the first paper on this subject by John Violet and colleagues 2019, when they indicate significant correlation between whole body tumor absorbed dose and PSA response. And they said that patients with less than 10 grays to the whole body tumor unlikely could achieve a fall in PSA higher than 50%. And they also find that significant correlations between gallium PET-CT and tumor and normal tissue absorbed doses provide the rationale for patient-specific activity. Summing up, concerning lutetium dotatate, the constraints for kidneys seem to be higher than 23 grays by means of absorbed doses or biological absorbed doses higher than 40 grays, cumulatively at 7.4 grays per cycle. Absorbed doses correlation for tumor's response have been derived with dependence on tumor grade, and dosimetry-based personalized critical protocols improve progression-free survival and overall survival. Better rationales can be provided, probably with a higher activity per cycle and a fixed number of cycles, for example, 4 cycles. As concerns lutetium PSMA, significant correlation between whole body tumors, absorbed doses, and the PSA response have been obtained. In responder patients, significantly higher absorbed doses have been found for lymph nodes and bony lesions, and absorbed doses from a gallium PSMA PET-CT seem to be predictive of absorbed doses in normal organs, but are more critical for tumors. Absorbed doses to target lesions versus cycles indicate the highest absorbed doses at first cycle, decreasing in subsequent cycles as well as observed in lutetium dotatate, and cases of kidney toxicity emerged in the case of retreatment or overtreatment. Now, clinical authors demand dosimetry and biological models. So, in summary, the raising practice of dosimetry provides crucial information on diagnostic potential and therapy optimization with relevant absorbed dose effector relations, response toxicity, progression-free survival, and overall survival. And of course, deepening radiological studies, disease-specific and radiopharmaceutical-specific, and models are essential challenges. Well, thank you very much for your attention. I hope you enjoyed the results obtained so far in this field.